Okay, so let's see if I can get this working. Shanna, are you on here? Hi. So I might need your help because if I can't if I get, let's pretend I get a bunch of questions and they're like scrolling up and I can't get to them fast enough because I'm answering the last one. I don't know how I'm going to do that. So I'm trying to watch it on both my computer and on the phone. So we'll see. See if anybody has some questions. We'll officially start in about 4 minutes. Who's on here? Oh, thank you. I used a flat iron. What's an anniversary follower? Hi, Molly. So I guess there's a few people watching. I only need not a ton of people because I don't know how many questions I can answer in a half an hour. But if there are no questions, then we'll just end it early, I guess. So we're essentially going live, and we're live now, but I guess we can start. If anybody watching has questions, then go ahead and type them in, and I will do my best to answer them or make something up or whatever. If there are a lot of questions for some reason and I can't get to all of them, or if there's a question that seems like it's going to have a really long answer, I can, after this, go back and go through the comments and either type out an answer for you or post a video that's not live with that answer. Or if there's enough people interested in watching, we can go to next week and I can carry questions over. But I have no idea what kind of questions people are going to have or if they have any. But yeah, so we're going to just play it by ear and figure it out as we go along. So you guys, can everybody hear me okay? Hi. Oh. Any problems with the sound or the connection? You guys are hearing me okay? And yes, no? Thank you. Shannon, I keep saying you're an anniversary follower. I want to know what that means. All right. Well, there's a few of you here, so welcome. Who has questions? Who brought questions? Who wants to know anything about addiction? You can ask about a specific drug. You can ask about withdrawal. You can ask about treatment. You can ask about the disease process. Like I said, I'll do my very best to make it up if I don't know it. That's what I do. You are the best. Yes. Hi, Jamie. Yeah. Oh, Jilly. Hi. Okay. So there's a bunch of you watching. Somebody's got to have a question. Okay, Jilly, thank you. I'm glad that you hear me. Let's see. Okay, so I can see it on my computer too. So, relationship. Robin, what about relationships? Hi, Kim. Or Robin, are you requesting a relationship? Because I'm already married, but thank you. Just kidding. Yeah, I don't know. I'm not sure what the question is. Aw, thanks, Chili. So, yeah. Nobody has any questions. Okay, so then let's just start talking about addiction in general, right? That's pretty much what I do. So, and I usually do, the addiction. Oh, okay. Nope, never mind. See, I guess I just have to start talking. So, a brother in hospital now, alcohol related. Okay. What question do you have? Okay. So Kim, the addiction unit at Worcester Hospital wasn't an addiction unit. It was New Vision was a national company that actually does medical stabilization. They can't call it detox, but they basically detox people in the hospital. They have pulled out of Worcester Hospital. They no longer have an agreement. But I have some knowledge that something may be coming down the pike. So I don't think Worcester's going to be completely left high and dry. And do you prefer the Vivitrol shot over Suboxone, or do you feel Suboxone is just as good? Okay, that's a great question, right? So we know that Vivitrol is a blocker and Suboxone is an opiate blocker and an opiate. And so all of the data shows that actually both work the same in terms of short-term continued abstinence. They both work the same in longer term continued abstinence. But they both have pros and cons, right? So, the Vivitrol shot, I like the idea of an injection because I like the idea of taking the behavior away of having to take something every single day, right? That's because addiction's not about drugs, it's about behaviors and thoughts and feelings. So if you have to wake up every day and remember to take something, or you feel a certain way if you don't take something, that almost like contributes to keeping a little bit of the addiction active. So I always prefer to be able to give something long acting or longer acting. I prefer a once a day medicine over 3 times a day, or an injection. But the problem with the injection, I find, is that most addicts want a drug to treat their drug problem, right? They don't want to do like the actual internal work that's required for really long-term recovery. And so when you give somebody an injection, they like to think like, okay, I'm good, and then they don't show up. They don't show up for counseling, they don't show up for group, they don't go to meetings, and there's really nothing I can do because they've already got their medication on board. And then they come back in for their next injection, maybe. If they haven't relapsed, then they kind of are feeling like, well, clearly it worked, so I don't need to do all that stuff. So there's a struggle with that. But as far as what works, they both work. They really do. And it just really depends on the person and what they want out of it. And as long as they're really informed about what the medications are, and what the cons are, and they're willing to engage in the actual treatment part of it, then either one is really fine. Like, it's called medication assisted treatment, right? So the medication is assisting the treatment. You can't call it MAT if you're not providing any treatment part of it. So yes, when used correctly, I feel like they're both equally effective in different populations and for different reasons. That's a good question. Hi, Sherry. I don't know who your nephew is. And I don't know what sounds like him. So what else? What other questions do we have? Anything? Okay. So, let's see. What do people want to talk about in terms of addiction? Treatment. Uh-oh. Uh-oh. I just turned my sound on my computer like an idiot. So I'm clearly not technologically knowledgeable. Oh, okay. Yeah, Vivitrol shot with no commitment. Yeah, that doesn't work. Nothing works. Nothing without a commitment to treatment is going to work. Like short term, yeah, it might for a period of time. But you know what else works short term? Putting your family and your job and all these other things as the priority. I mean, people can white knuckle it through months of not using, even without any medication. But it generally is not going to last much longer than a year at the most, maybe two, depending. But yeah, my thoughts on methadone. Same. Because methadone has those very specific state regulations, and it varies by state, and there's federal guidelines as well. You can't prescribe methadone out of an office unless you're doing it for pain, and then you have to be a pain specialist, and they can't have a history of addiction, and the dosing is very, very different. So if you're talking about methadone for substance use disorder, which obviously you are, 'cause here we are, methadone, I think it offers a component that's different than the other medications in that the accountability. You have to go daily and dose, and you actually have to earn the ability to take home doses and be able to take it on your own. The problem with methadone, though, is because when it came out in the 70s, it was a harm reduction model. It wasn't a medication-assisted treatment model. So they did have counseling and stuff, but they were really more concerned with getting people off the opiates, getting the needle out of the arms, reducing the risk of hepatitis, HIV, endocarditis. And so it was really more about just stopping the heroin use, and there was less concern about stopping the use of other substances altogether, which is fine if you're a harm reduction person and that's, you think that that's okay. For long-term abstinence, we don't see that work very well. So the movement for many methadone clinics, and I certainly can't speak for all of them, but I know for mine in Erie, the Esper Treatment Center, where I'm the medical director, and I think Community Health Center here in Akron. I know there's other ones around here, but I think that we're all kind of trying to move towards this medication-assisted treatment model where methadone is now just being a part of the treatment, and they're providing IOP, and they're providing more counseling, and they're really requiring people get involved with some other outside communities to help stay sober, and they're not being as tolerant of the use of other substances anymore. I think that methadone is a really good option, though. If people really feel like they need the accountability, I think it's a good option. It's also a very good drug. It's long acting. In the correct dose, it will eliminate cravings, and at least theoretically, in the correct dose, it'll block the ability to get high from other opiates, similar to the Suboxone. So, those are good questions about MAT, though. I think a lot of people have them, and I can clarify further if people have specific questions or need more clarification. Hi, Brittany. Okay, my sister's been on methadone for 5 years. She gets it from a clinic. She's wanting to get off of it for good, and the clinic will not lower her dose. Now she is thinking of going cold turkey. Oh, good God, no. Okay, so obviously, I don't know how much communication you do, Bobby, with your sister's clinic. I'm assuming probably not much. So the question would be why? What is the reasoning behind not wanting to lower somebody's dose? For me, the only reasons that I would refuse to do that for somebody is if they are still actively using, and or if they're not really engaged in other elements of treatment. So if they're, everyone in their life is no longer actively using, they have a safe environment, they're working, and they've been abstinent, providing clean urines, and they want to taper, I would absolutely taper. So I'm not sure why they would refuse it unless there's something else going on. Now, if for some reason they're just like, nope, everybody stays on methadone forever in some kind of weird place. I definitely would not recommend going cold turkey. Honestly, I wouldn't. Methadone is a very, very powerful opiate, and it is a very long acting opiate. And depending, I mean, she's been on methadone for 5 years. So remember this. This is really important too. This is my little segue or side note. But with buprenorphine and with methadone, right, both of them are long-acting opiates. So here's what happens. When someone's using heroin on a daily basis, or they're using pain pills on a daily basis, they're going through withdrawal to some degree over and over and over. Like every day, they're having some degree of withdrawal. And then usually there's a day or two they can't get any drugs, so they start to go into full-blown withdrawal. Then we put them on a long-acting opiate, like buprenorphine or methadone. And for months and months and years, they don't go through any withdrawal at all because they're stable on their medicine, right? And so what happens is when we do taper them off or they stop taking it, they go into withdrawal. Now, it's still pretty uncomfortable and pretty awful. But the problem is the relativity, right? It's that they haven't experienced withdrawal in so long that it hits them very hard and they think, oh my God, this is worse than heroin withdrawal. Both buprenorphine and methadone withdrawal will last longer than a heroin or a pain pill withdrawal. But I don't think the intensity is actually any greater. It's more of that relativity of not having had any withdrawal for a period of time. But I definitely would not recommend doing it cold turkey. Detox units sometimes will detox people off of methadone, but usually you have to be on a pretty low dose. And I'm not a proponent of like lying or having her go in and say that she's having symptoms of feeling too tired to try and get lowered. I would just really look into questioning why, and if there's no valid reason, see if there's a way she can transfer to a different methadone clinic that is willing to taper her, because it seems like you're setting somebody up for failure. Hi, Melissa from Erie. Oh, yeah, hi. Thank you. Okay, she was addicted to pain pills, had 2 kids on methadone. Good, both kids are good. That's always glad to hear. It does take time. Okay, so the methadone clinic claims that it takes time. I mean, I totally agree with that. It does take time. It takes a very long time to properly get off of methadone. The recommendation is really no more than 2 milligrams every week or every other week. So depending on what dose someone's on, that could take a really long time. But certainly sometimes people can tolerate like bigger jumps, at least in the beginning, if they're on a higher dose, and then slow down as you get lower on the dose. But yeah, I don't have a good answer as to why a specific clinic would do that, or what the issue is, unless, of course, she's saying like, I want to drop 20 milligrams a day or something like that, which would be crazy. Patient stopped methadone cold turkey and had a horrible seizure. There would have to be an underlying seizure disorder there, because opiate withdrawal typically will not cause seizures. There's no mechanism that would do that. But if somebody had an underlying seizure disorder, undiagnosed seizure disorder, and or there was anything else involved, obviously coming off of benzodiazepines or alcohol, those withdrawals will definitely cause seizures. And then being high on meth or cocaine can cause seizures too. So it's unlikely that methadone by itself caused a seizure, unless there was something underlying to begin with. I'm not saying it's not, anything's possible, right? In medicine, anything is possible. But it's really unlikely. And in the 15 years that I've been doing methadone, I've never seen someone have a seizure from withdrawal. From methadone alone. But yeah, it's pretty, I mean, it's awful. There's no question. Opiate withdrawal is awful. No matter how you do it, when you do it, and what you're coming off of, it is like the worst flu you've ever had in your life. And then you consider the fact that opiate addicts have absolutely no ability to tolerate discomfort at all, right? Period. Like, cannot handle anything. And now you're throwing them into this insanely uncomfortable situation and being like, oh, well, you know what, suck it up. It's pretty horrible. It's a pretty horrible situation, which is why they started using like methadone and buprenorphine and having them go to detox where they can get comfort medications. It's not because it's dangerous. It's because it's so uncomfortable, and addicts have no tolerance for discomfort. So the risk of them going back out and using and then potentially overdosing is really high, and that's what's really scary. So, these are some good questions, you guys. Okay. Boy, Kim, you really brought the questions. I'm glad. Okay. Side effects of taking methadone for 8+ years. You know what? Opiates in general, including methadone, are really pretty safe. Side effects of methadone, if you're going to have them, generally you're going to have them right from the beginning, and certainly nausea and constipation. Sweating is one that people get. Sometimes, the problem with methadone in general is that a lot of times too high of a dose and too low of a dose look the same. They have similar symptoms. So trying to figure out, where the person is at, is their dose too high or too low? You need to adjust. And you don't tolerate to methadone, so it's not like, after 2 years you have to go up because you're tolerating to it like other people, or like other opiates, sorry. But if certain things change, your metabolism changes due to a disease, or there's some situation, like you start working a third shift job in a factory that's 900 degrees and you're metabolizing it faster, or you take a new medication that's affecting your liver through the same pathway, then your dose would need to be adjusted. But there really shouldn't be like side effects that show up later in life. I know that there are rumors about methadone, like rotting teeth and getting into bones. As far as I know, it doesn't get into your bones. There's sugar in it, in the methadone, to make it tolerable to drink, and I think that sometimes has the effects of rotting teeth. How long do people stay on methadone? Could be lifelong. So the example I always use is that, oh my God, Kim, I'm sorry about your dad. So the problem, like, if I break my leg, I need to be on crutches for a period of time while my leg heals, or I need to be in a boot, right? Something to take the pressure off that leg. Most people with physical therapy, following up with their surgeon, doing all the things they're instructed to do, basically, eventually get off those crutches, right? But some people wind up getting a bone infection, or the bone never heals right, so they wind up in crutches on a wheelchair for life, or they lose their leg. The same thing is true for medication assisted treatment, right? We're giving it to kind of take some pressure off of the brain so they can focus on getting well. Most people, the goal is to try and get them off of it at some point, and most people want to get off of it at some point for the same reasons I mentioned earlier, that nobody wants to have to wake up every day and take something. But some people are on it, for life. Some people wind up on it for life. People that have tried over and over and over in different ways to sorry about my hand, to get off of it, or to go to different treatments or whatever, and they have been unsuccessful. They're on it for life. So I mean, again, I'm super sorry about your mom and dad, or your dad. I don't know the circumstances there to be able to give you a solid answer about that. But again, I've been running a methadone clinic for quite a number of years, and I haven't really seen problems like that. The problems I see are with the people that don't want to engage in any treatment, and they continue to use outside of the medication, and that's where they wind up having difficulty. Combining methadone with other things can be really dangerous. It's a very, very, very hard on your liver drug. So if you're taking other drugs or using medications and they're interacting with the methadone, hopefully the clinic would be aware of that, but that could be really problematic. Let's see, Colleen. Food addiction. Okay, is so bad because you can't stop eating. Okay, food addiction is a process addiction, right? So food addiction, you treat it the same way that you treat other addictions. So counseling, and certainly there are 12-step groups for food addiction. There's Overeaters Anonymous, and then there's Food Addicts Anonymous, and there are two kind of different premises. Overeaters Anonymous, that, you know, they look more at this, the binge type eating, like you're eating to comfort and it doesn't matter what the food is, you just can't seem to stop eating. And then there's Food Addicts Anonymous, where you crave specific foods, and those specific foods are what trigger the binging, or the guilt and shame that comes with it. And so a lot of that has to do with looking at, you know, what the underlying problem is, your inability to cope with life in another way. What kind of relationship do you have with food? A lot of this stems from your childhood, and the kind of environment you grew up in. Like, what was your parents' relationship with food? What role did that play? But with food addiction, what you really have to do is identify. Obviously, you can't give up food. You can't stop eating, right? That you would die. But what you really have to do is you have to identify specific trigger foods that when you like crave them and eat them, it's almost always an emotional response, and then when you do that, you seem unable to stop. For a lot of people, that's sugar, but certainly refined carbohydrates in general can do that. For some people, it's, you know, dairy. I mean, whatever it is, you have to look at that, and then you have to eliminate that food from your diet. You have to remain abstinent from that food in a way that a drug addict or alcoholic has to remain abstinent from their substance. So it's challenging because food's everywhere and it's widely accepted and it's part of our socialization and our culture. So it can be a really tough one, but I definitely suggest getting supports. Like, I think the 12-step fellowships are great, but there's also probably support groups, even online, that you can talk to other people about, you know, how to deal with that. And then probably seeing a counselor and trying to get to the root of, you know, that relationship with food. There's I'm not like paid promotion of anything. I'm not trying to promote anything. But I personally use the Noom app, the Noom. I'm sure you've probably seen a commercial for it. It's a paid app, but it's based on psychology. And it's very, very simple, you know, daily things to sort of reframe your thinking. And I know that there are other apps and there are other programs out there that look at that. And that's kind of the goal. Like, the goal is not to get on a plan where you're like measuring out your foods and necessarily counting every single carbohydrate or macronutrient. I mean, that can be helpful for some people, but that's also really hard. And it doesn't change the relationship. So anybody can do some things for short periods of time, right? So anybody can do food prep for like a month and feel really gung-ho because you're in a 30-day or a 90-day program to like control your eating. The problem is, how do we sustain that? And that requires digging a little bit deeper and working more on the relationship you have with food. But certainly, if you're using anything, any behavior to cope with emotions and stress, and it's becoming unhealthy or causing you problems, same thing, you're gonna have to look at that, at like what the relationship is there and what the benefit is of continuing that behavior, and then finding supports to help you reframe those behaviors. Hey, Teresa, you can't escape this place, right? You're not here, and here you are. Hey, Chrissy. What else, you guys? These are great questions. I'm super glad you're all here. No? Okay. Well, I'm not addicted. Divorced my husband, who is an alcoholic. Good for you. He has 2 relations. Okay, great question, Deb. So just recently divorced, alcoholic husband, and he has had 2 relationships in the last 2 months, requesting women to move in. Is this normal behavior? Okay, so let's remove the word normal, because there's no such thing as normal for an addicted brain. The addicted brain does things that doesn't make sense in normal society. Is it common for an alcoholic to start fixating on relationships and become codependent? Absolutely. It's the same as trading one drug for another. relationships, particularly early relationships, you know, when you're like totally lusty in love and all the chemicals and pheromones and you're like, oh my God, I totally get this person and like all that. That releases a lot of dopamine in the brain, just like drugs do. So, particularly, you know, now that, you know, you're divorced and he has kind of probably this freedom, there is a lot of cross reactivity between the addicted brain and then relationships, particularly fast moving relationships. And it's codependency is what it is. Seeking that substance to fill the hole in your soul through other people, using other people to stuff in that hole to try and make yourself feel whole and better. Oh, thanks, Kim. Yeah. But that's, I mean, relationships are a big deal. They really are. Relationships release a lot of dopamine there, and they can be very healthy or they can be very unhealthy. And like one of the things we always tell people, anybody that's in recovery will tell you, one of the big recommendations is what? No relationships for the first year, right? We tell you that all the time. Why would we do that? Because we're mean and we want addicts to be alone and miserable. Yeah. No, we tell people no relationships in the first year because relationships release a lot of dopamine, especially again, those early relationships. And, you know, addicts will put all of their focus into something that makes them feel good. And so when they're doing that, they're not focusing on doing the work to stay clean. And so it provides sort of an escape route. And then it also stops the brain from healing because the brain's getting the dopamine it needs from that relationship. So it's not healing. It's not coming back to that normal place where it gets pleasure from other things. And so when that relationship turns bad, or turns to like a normal relationship where you recognize the person has flaws and stuff, then you stop getting as much dopamine from it, but now you have no coping skills because you haven't been working on coping skills because your relationship was your coping skill. So it's really better to avoid new relationships in early recovery and really focus on yourself. I also like to say that broken toys only attract other broken toys. So if you're 2 months clean from a 20-year addiction, who is attracted to you at this point? Like probably only other people that have a lot of baggage and damage. And it's not a criticism. It's just a reality. You know, we do a lot of damage to ourselves in addiction. Philippe, you are welcome. Thanks for being here. How do you deal with a family member that's gone off the wagon without intruding into their life? Okay, alcohol. Yeah. Okay. It is the hope of every alcoholic to be able to someday be a normal drinker. I believe it says something to that effect in the big book of Alcoholics Anonymous. So, you know, I don't like to give advice to families about how to deal with their loved ones that are addicts, because everybody has their own sort of muck to wade through. But I do like to say that, you know, the most important thing is that we all take care of ourselves. We set up boundaries that keep us healthy and safe. And if we're not taking care of ourselves, we're really no good to anybody else, right? So if you have an alcoholic or an addict in your family who has relapsed, you can offer support to help get them back on the wagon. You can offer support to help get them to treatment, to meetings, to, you know, to group, to therapy or whatever. But if they're just not willing to do that, you know, I think it's really up to you to set a boundary as to what you're willing to tolerate or not tolerate. Like, hey, you know what? I know that you cannot drink in moderation. I've seen it 100 times so far. And so I would really prefer that you don't come to any of our family functions if you're going to be drinking at them. I mean, that's a totally appropriate thing to say. And if somebody's going to get mad at that kind of direction, that's on them. You know, that's really on them, because you can say, you know, hey, we're having a party at our house. I'd prefer you don't smoke in my house. Like, you have that right. Right? And smokers have to go outside. If you know that someone drinking is going to escalate at some point and you don't want to contribute to it, then just don't. You know, you just don't. Let's see. What am I missing here? Oh, boy. Oh, I know. Families, Sherry, you are so right. Families are the ones that definitely really struggle because you don't understand, right? It's not possible to understand it. if you haven't gone through it. But you love these people and you want to see them get well. And it's so frustrating that like you can't just hold the mirror up and be like, look at yourself, you know, and they just can't see it. It is really tough. But the only thing you can do is set a good example by taking care of yourself. So hopefully they will see that and they'll develop the desire to take care of themselves too, because they're seeing you do it. They want to do it. And then again, you set up a really good boundary for yourself. So, you know, that's the best way to do it. I tell people, go to Al-Anon, go to Nar-Anon, go to whatever 12-step or community support group for families of addicts. If your church has one, that's great. Do that. You know, get yourself involved with other people who have addicts. You're not going, you know, to find out how to fix your addict. You're never going to be able to do that. But you go to learn some skills about how to take care of yourself, how to lovingly detach, how to set up some boundaries, because you're never going to make your addict want to change. They have to come to the point where enough is enough for them. And nobody can determine that. Some people can be lying in the hospital with their bellies out to here, in complete liver failure, in need of a transplant immediately, and they still want to drink. And the doctors are going, oh, this is his bottom. And I'm going, you don't get to decide that. You know, they have to decide that for themselves. There's other people who simply, you know, a relationship ends or their kids say, I'm not going to talk to you. And that's enough. That's enough of a bottom for them to say, okay, I have to stop doing this. We can't make that decision for the addicts. You know, they have to come to that decision themselves. However, what we can do is assist in helping them reach that by engaging the consequences, right? So if it's going to take the loss of certain relationships, or at least a step back from certain relationships, if it's going to mean cutting them off from finances or from, you know, housing support or whatever, if that's what it's going to take for them to reach a point where they're like, I got to stop, this is causing too many problems in my life, well, then maybe that's what needs to happen. But again, I can't make that decision for anybody. I mean, you guys really have to make that decision. So what else? I mean, we're close. I mean, it's 12:30 and my intention was to stop this now. I will answer a few more questions if people have them. Obviously you can watch the replay, but you guys want to come back next week? You want me to do this again? Do you feel like it's been helpful? What do you want me to try and get questions ahead of time? I mean, you tell me. This is for you. I'm doing this for you, right? I don't particularly like to see myself on camera, but yeah, I mean, I do like to hear myself talk, so, but I don't need a camera to do that. You guys tell me what you want, and I'm happy to do it. Hey, John, I'm super glad. I'm glad you're here. Yeah, okay, good. Shannon, you don't, I love you, but you don't count. Okay, Jess. Watch the replay for sure. Okay, good. So what I'll try to do is schedule this like around the same time, maybe Fridays at like noon. I think generally my schedule has some openings there. So I'll post another event on my page for when I'm going to do it again. And again, if I get, I mean, you know, there's quite a few of you watching. I'm happy to see that. So I am, as long as I keep getting that kind of response, I will gladly keep doing this. So, yeah, so just get your questions ready. And, oh, Brittany, I'm so glad. Oh, you guys know I have a book. I have a book coming out. It'll be out, I'm thinking, the end of September, beginning of October. That's what I'm shooting for. And it is really my Addiction 101, like the lectures that I give, but where I can expand on things because I'm usually limited on time, so I can't like go off on a tangent. So my book let me do that. So so it's the Addiction 101, and there's some pieces of my story, and there's some stuff about, you know, just interactions I have with patients. So that'll come, and then again, I'll probably post a ton of like stuff when that's ready to come out. So if people want to get that, it'll probably be on Amazon. So anyway, great. Yes. So Friday at noon, unless I have something specific, but I will let everybody know. I will post it. And so I guess I will see you guys next week. And anybody that didn't get to see this and is watching the replay, go ahead and post your question in the comments, and I will try to get to it. And again, if it's something I can answer quickly, I will type you a response. And if it's something that I feel like a lot of people might want to know, maybe I'll make just like a not live video. I'll just record a quick video of an answer and I'll post that for you. So yeah, just keep bringing your questions, and I'll see you guys next week. And Shannon's going to help me boost the event, whatever that means. So thanks, Shan. Okay, bye everybody.